Right, okay, right. I think that's enough time, so I think we should make a start before we get too far behind. Hi everyone, my name is Hannah Crouch and I'm the editor at Digital Health. Today's best practice webinar, we'll be discussing how to leverage data when dealing with long COVID, with provider organisations and scientists turning their attention to analysing and managing the effects of long-term COVID. The need to capture precise and granular clinical documentation at the point of care has become increasingly important. Our panel today is going to be exploring how to capture accurate and complete SNOMED codes with clinical interface terminology, leverage granular clinical patient data to help organisations manage the long COVID patient population, and learn the importance of standardising clinical documentation. Our audience today is going to be hearing from Stephen Rube, who's the Senior Vice President for Global Clinical Services at Intelligent Medical Objects, and June Bonmert, who's the Senior Director for Global Clinical Services at Intelligent Medical Objects as well. During the Q&A, we're also going to be joined by Dr. Paul Altman, who's the CCIO at Oxford University Hospitals NHS Foundation Trust. Speaking of the Q&A, we will be holding one after our presenters have spoken. Those with questions, you can ask them at any point during the webinar. You can submit them in the Q&A section, and that's the best place to do this. And you can also vote for your favourite questions. There's a little thumbs up next to questions. So if you like the look of one, give it a thumbs up and it will bump it up my list. And if you want your question directed at someone in particular in our panel, please let us know. And just one final thing, this session is going to be recorded and will be on demand a few days after the webinar. I'm now going to stop talking and I'm going to hand over to our panel. So I think, Stephen, you're up first, so it's over to you.
Thank you very much. Welcome. Thank you very much, everyone, for joining today. Real quickly, we always like to start with a few objectives as they were stated. We're going to speak to how clinical interface terminology, which is a phrase you're going to hear often throughout today's presentation, clinical interface terminology, how it can facilitate accurate and complete capture of SNOMED codes. We understand the importance of adding structure to clinical data, and that's going to be one of the points that we're going to stress. And then we're going to try to speak to how this data can be leveraged. We realize that that could be an entire presentation, an entire day's seminar on its own. But we're going to start to scratch the surface on how we can leverage some of this clinical data, both retrospectively and prospectively. So real quickly, first we'd like to give a few moments to who we are at Intelligent Medical Objects. We've been around for quite a while. That first statement, I don't like to read slides, so that first statement is really the one I like to focus on. We're a healthcare data enablement company. We've been around, particularly in the United States, but we are now in 17 countries, including the United Kingdom and Australia, Canada as well. A simple way to think about Intelligent Medical Objects is we provide clinical content to people practicing medicine at the point of care. We provide it in a language with which clinicians, and when I say clinicians, I don't just mean physicians, I mean physicians and nurses and anyone taking care of the patients at the point of care, in the language in which they were taught at the level of specificity with which they need. We then provide the maps on the back end to the appropriate administrative and standard code sets that are absolutely necessary in order for hospitals to function in this digital landscape. So we really allow those two worlds to play nicely together, where in the past, the clinical and the coding world have not played all that well. As I said, in the United States, we've become the ubiquitous choice for clinical terminology, and we're looking now to bring that to other places in the world, including, as I said, the United Kingdom and Australia. I'm not going to reread this. This is the introduction that we just heard as to the point of it. What we're seeing, though, and in no way do we want to imply that we're completely going to declare victory over SARS-CoV-2 virus at this point. But we are seeing a bit of a change in certain countries. Now, we understand that acute COVID in parts of the world, in India and so on, is still, quite prevalent. But in areas like the United Kingdom and in the United States, we're starting to see a shift now as vaccinations become widespread, where the acute phase of the illness is becoming less prevalent. And we're now starting to have to look at not only vaccination efforts, but some of the chronic conditions that we're seeing, that they're seeing step up. And whether we refer to these as chronic COVID, long hauler COVID, we know that medicine loves to play with terminology as far as naming things differently. That's one of the issues that we're going to have. How do we describe these conditions? How do we track them? How do we learn from them? How do we treat them going forward? So why do we need granular clinical terms? Why not just use the standard and administrative code sets? Well, first of all, neither SNOMED nor ICD were designed for clinical documentation. That's not an insult to either one of those two terminologies. Some would argue whether ICD-10 is actually even a terminology rather than just a categorization system, but they were not designed for that. Now, SNOMED is quite a bit more clinical than ICD, but still, its mandate was about the collation of data for reporting and analytics rather than actual clinical documentation. Why you need clinical descriptions to accurately describe what is going on, whether it be COVID or any other clinical situation, these are just some of the use cases as you see on the screen. This should all bring back some memories to about a year ago. When we were having difficulty even describing accurately the patient's conditions. When ICD first introduced codes for COVID, I believe there was one code in the United States and 2 codes worldwide. That was it. The rest were added codes that needed to be concatenated in order to come up with an accurate coding. We believe in creating descriptions that capture the clinical intent at the point of care. So once again, to accurately capture the patient's condition, to describe comorbid conditions and effects, to describe the many different manifestations from people who had no symptoms at all to people who were severely compromised, to evaluate treatment measures, preventive measures, to track outcomes. As we move into this new phase of immunization, we're going to need to track the effects of the immunization, the side effects, not only overall of our immunization effort, but by type and by brand as well. And as we said, we're going to need to accurately create cohorts going forward. And this will assist in any other research, as I said, prospective or retrospective analysis that we want to do. So this is a very important statement. Clinical interface terminology, such as the one IMO offers, does not replace SNOMED CT. As I mentioned earlier, SNOMED is absolutely going to be the standard for which reporting and analytics are based. Many countries have governmental mandates for reporting and capturing SNOMED CT codes. It is absolutely imperative that these be captured and reported upon. What clinical interface terminology does by delivering, well over, in this case, 300,000 clinically intuitive terms, we provide easier and more accurate paths to both SNOMED and ICD. We do not rely on cross maps. We match each one of these terms individually to both SNOMED and ICD. And that allows the clinical people, once again, doctors, nurses, therapists, and so on, to really concentrate on just saying what they're trying to say clinically. And the accurate maps will happen either overtly or covertly behind the scenes, which will then be available for reporting. So the question that often comes up, though, is how do we do both? How do we provide our clinicians the ability to capture clinically what's going on, as well as complying with government, regulations, in this case, NHS requirements to report. Agencies trying to do this themselves realize that this is quite an intensive effort to kind of manage this mapping. And what often happens is the clinicians are relegated to using either SNOMED or ICD as their documentation source. And it's not usually received very well. As I said, those terminologies do not exist in the language or at the level of specificity needed. So let's do a very oversimplified diagram on the life of a clinical diagnosis or a clinical term. So what we have is we have the doctor at the bedside, interacting with patients, and hopefully with the electronic medical record not becoming too much of an intrusion into that interaction, and coming up with a term, in this case, COVID-19 long hauler with persistent shortness of breath. I think to myself and to most clinicians out there, this would be considered one clinical term, one clinical description capturing an idea. That's what I want to say, and that's what I want to say. So you're able to capture that and you're able to move along. What clinical interface terminology allows for in the background is that the appropriate SNOMED maps by teams of people who are absolutely, experts in these terminologies, and they're not clinicians necessarily, although we as physicians like to say that we're experts in all things known to man. In the coding world, we're not usually experts in that. So I will not claim to know how to code and map everything to SNOMED or ICD. So I leave that to people who are experts. That group of code maps, in addition to the clinical diagnosis, now have structure. And that structure can then be stored in your EHR or any other data platform with which you have access to. Once it's stored there, once it's exported for reporting, whether it's to the NHS or any other government or any other agency, be that public or private, those computers on the end don't really care how those SNOMED codes or ICD codes or any other codes were obtained. They just need to know what they're seeing on their end. They read SNOMED, we will give them SNOMED. And that, as I said, is the more accurate grouping of SNOMED codes that were obtained there. But if you just read those COVID-19, post-COVID-19 syndrome and chronic dyspnea, it's two separate terms, even if they're linked together, don't actually capture what was being said in that original clinical diagnosis, certainly not as smoothly. We can do this because our interface terminology is, taller and wider. We also don't have the inherent problem of post-coordination needed for things like staging and laterality. Staging and laterality are post-coordinated in SNOMED by design, and that's an important thing. IMO doesn't necessarily need the user to do that. We'll provide those terms in a pre-coordinated fashion. We'll also provide them, as I said, at the level of granularity. So in the world of precision medicine and genomics, when you need to say chromosomal alterations of group C and X, you can say it rather than just chromosomal abnormality. This becomes very important when you're trying to move data around. So to use that same COVID-19 clinical description with those same code maps, now you see the appropriate ICD code maps added as well. When you try to move them using a conversion SNOMED to ICD table, you end up pivoting on that preferred primary code of post-COVID-19 syndrome. Excuse me, for SNOMED, you end up pivoting to emergency use of UO7.4. I don't know about you, but most doctors don't speak in that language. I would never tell a patient, sorry, you have the emergency use of UO7.4 as your diagnosis. However, that is the term that you end up with in ICD when you pivot on that preferred primary ICD code. With an interface terminology, you move that entire clinical term over with the maps handled on the back end. So that's really where interface terminology comes from. We think it's so important when we start to speak of COVID. In the interface terminology world, we've released approaching 500 clinical descriptions related to COVID and long COVID over the last year and continuously releasing more. This fits just into one part of our portfolio, the IMO Core product that we have. We have others that provide insights as well as other content solutions. We'd be glad to, handle some of those inquiries, additionally outside of this conference. But I'd now like to turn it over to June, who will get into the more specific uses of interface terminology and long COVID. Thank you, June.
Thank you, Dr. Rube. It is my pleasure to be here today. And let's get started by looking at the definition of long COVID. So, as you can see, in October 2020, the National Institute for Clinical Excellence published the following definition as seen on the screen. The condition usually presents with a cluster of symptoms, often overlapping, which may change over time and can affect any system within the body. We're going to take a closer look at various signs and symptoms next. So just as with COVID-19, long COVID conditions present in a variety of fashions with varying degrees of severity. This is not an exhaustive list, but rather signs and symptoms seen across different body systems. Brain fog is difficult thinking or concentrating. Shortness of breath, fatigue, and brain fog are the three most common symptoms reported. The condition may affect single or multiple body systems with fluctuating intensity. Long COVID-19 is being seen both internationally and nationally. The NHS has published a response that we will review in closer detail. The NHS has established a multi-pronged approach for long COVID-19, known as the 5-point plan. We're going to look high level at each point, as all points require timely and accurate clinical data. The first point provides clinical guidance. These guidelines help providers identify patients with the condition, along with a clinical pathway for treatment and ongoing patient management. Another point is an individualized program known as Your COVID Recovery. This program is tailored rehabilitation support for long COVID-19 patients. Provider organizations must register as a service and participate in the training in order to enroll patients. Once patients are enrolled, an interactive individualized care plan is created. In addition to the individualized plan, general information is also available via a public-facing website regarding the various aspects of long COVID. The NHS is also providing funding for long COVID-19 services across England to align with existing services. And while the healthcare community has learned a lot about the condition, we need to continue to advance our knowledge through research. And to this point, another point of the 5-point plan, NHS has invested additional funding for the National Institute for Health Research for long COVID-19. The last point of their plan is creation of a task force. And the task force is comprised of patient representatives, clinician researchers, charitable organizations, and other necessary representatives to advise on the plan and support the implementation of the 5-point plan. All aspects of this plan require appropriate capture of the patient's clinical details. And in the next section, we will review an efficient way to document the details. So just like painting a picture, many different colors are necessary to represent the full image. It's important for clinicians to paint the patient's clinical picture in their documentation. And next we will see how IMO facilitates documentation capture in a generic electronic patient record system. So here with IMO Core, clinicians can use the intuitive language to search for a condition. In this example, the clinician is searching for the condition COVID-19 long hauler with chronic palpitations. And as you can see, the provider typed COVID and a list of terms was presented, and they could efficiently select COVID-19 long hauler with chronic palpitations. Given the single term includes the primary condition and comorbidity, the clinician will be able to easily build an accurate clinical history for this patient. And in contrast, you will see that without IMO, that multiple clicks are required. Also searching for post-COVID syndrome is seen, and then, notice the comorbidity condition is not captured. An additional search for chronic palpitations is necessary. And so on this next piece, you can see by having the terminology COVID long hauler with chronic palpitations, both codes, as Dr. Rube talked about, are presented and captured along with the clinically friendly term to identify that the palpitations are related to and due to COVID. So now we are going to look at the patient population. And so the NHS estimates 1 in 7 people testing positive for COVID-19 have ongoing symptoms at 12 weeks. And again, in October 2020, NHS England and NHS Improvement announced a £10 million investment to help local services. In March 2021, NHS England and NHS Improvement provided further contributions of £24 million for post-COVID assessment clinics to support the anticipated demand for these services in 2021 and 22. These figures show the impact of the disease, not only on the healthcare community, but most importantly, individual patients. So identifying and managing this patient population is important. And while they can present unique challenges due to the range of signs and symptoms, capturing the details in a structured format is key. And we will look at how IMO structured data can support the various efforts, starting with the continuity of care. Here you can see the IMO powered condition list clearly displays the linkage of chronic joint pain due to COVID-19 versus the patient's other chronic musculoskeletal conditions. And the non-IMO powered condition list displays chronic joint pain independently from COVID-19. The provider would need to access additional information to verify that chronic joint pain was due to COVID-19 and not other conditions such as osteoarthritis. A strong terminology foundation is maximized by ensuring this data entered going forward is structured and coded to the industry standards. So keep in mind, some of these patients did not receive medical interventions during the initial phase of their COVID-19 disease. So having the specific signs and symptoms clearly linked and codified is important to leverage the data both internally and externally. Internally, the organizational data supports holistic coordination of care. For example, long COVID-19 patients with shortness of breath can be distinguished from long COVID patients with palpitations. And this subsetting lets providers monitor and analyze targeted treatments and social support for the specific patient population. And next, we're going to look in further detail at the external types of services which require coordination of care. Assessments and treatments are multidisciplinary, requiring the coordination and communication across all roles and functions. And having better data leads to better decisions and improved communication across the teams. Examples of the services patients may require one or more of are as follows. The physiotherapist, which offers support, rehabilitation, and self-management advice for patients dealing with symptoms such as breathlessness, deconditioning, fatigue, and dizziness. Guidance on pacing and rest times are two examples of information they provide. Speech and language therapists provide support for swallowing, voice, including muscle tension dysphonia, and respiratory difficulties. Occupational therapists provide an occupational focused support for functional outcome, independence, and activity measures, including support for self-management and social prescribing. Psychologists can provide assessments for cognition, mental health, along with support for patients managing persistent symptoms such as pain and fatigue. Specialized nursing functions may support the family and the broader family needs. While finally, dietitian support includes advice on nutritional status due to loss of appetite or swallowing difficulties. Also, as part of the 5-point plan that we discussed earlier, the online interactive rehabilitation platform is individualized. It's designed to be an adjunct offering and not a replacement for the usual primary care support and rehabilitation services. So the assessments, treatment, and the patient online platform will contain key data elements in the fight against long COVID-19. Ensuring the data is captured in a streamlined fashion with industry standard code systems behind the scenes supports the communication across the teams. This also supports external data reporting as the NHS has established external data reporting, and we'll look at that next. The external reporting from your organization is key for operations, payments, and research. The NHS acknowledges the need for quality, timely data at various levels, ranging from local to national. The established UK data flows are top of mind for the NHS, as evident by a recent 11-page publication titled COVID-19 and SARS-CoV-2 in SNOMED CT, Advice on Competing International and UK Codes to Ensure Established UK Data Flows Are Not Disrupted. Data is reported via the social care situation reporting, and the goal is for the long COVID-19 data to be reported fortnightly. A national patient registry is being planned based upon reported data with the goal to provide insights into the longitudinal patient journey. So reporting data quality in a timely manner relies on strong terminology foundation efficiently captured at the individual patient encounter. And so finally, we will bring it all together with the power of clinical interface terminology. Assessing and treating long COVID-19 allows the provider to focus on the patient. The structured and codified data can be leveraged internally and externally to provide deeper insights into the patient's journey. Thank you. I'd like to turn it back now to Hannah.
Thanks so much, June, and thanks, Stephen. And so we'll bring back now for a Q&A session along with Paul Altman from Oxford University's Hospitals NHS Foundation Trust, which is a mouthful always to say. I'm just going to kick questions off. It was just kind of a technical thing, Stephen. You mentioned in your presentation about U07.3 and U07.4, which I hope I've written down right. Would you be able to explain the difference, if possible?
I would be, but since we have June on the call, it would be much more appropriate for her to. Otherwise, I'll hear from her later on, the part I didn't get exactly correct.
Yes, the U07.4 and U07.3 have both have titles around the emergency use. However, they have been designated to represent a history of COVID-19 and also post-COVID-19 conditions. So the U07.4 is the post-COVID-19 conditions, which is the linkage of the ongoing, like the long COVID, long hauler, post-COVID, for whatever manifestations the patient is having. Whereas the history code is to identify the fact that a patient had COVID and now is no longer experiencing any type of symptoms.
Okay, that was very well answered. More technical than I know.
I understand why I turned it over to you.
And someone just asked, I think they've enjoyed the slides so much, but if they'll be shared, which I'm sure we can do afterwards, we can share the slides with everyone, as it was a really great presentation. We've also had another question which says, how often are the IMO clinical interface terms added to or updated with the underlying mapping to SNOMED and ICD-10, not just for COVID, but in general? Who wants to take that one?
Sure. We do 6 releases a year standard. However, during the last year, that schedule has been turned upside down, needless to say, and we've done many more. So we can release, we've done up to 10 releases in a year. Now, how that becomes available to an end user will often depend on what platform they're accessing our terminology through, which EHR they use, which data management platform they may be using as well. We try whenever SNOMED releases terms, and once again, we can't compliment SNOMED enough on how they've handled this and what they're trying to do. They are also releasing emergency terms, and they were keeping up as well. So we're doing that, mirroring their releases as well, is in addition to when clinicians come to us and ask for terms, we need clinical term X, we will add that. So at this point, we're doing 6 releases a year, but you would need to speak to your individual provider to see how often they're making that available.
Lovely. Thank you, Stephen. And Paul, if you don't mind, I was hoping to bring you in, because obviously you come from the NHS side of things. How, from an NHS perspective, how do you think important it is to leverage and have this kind of granular data when it comes to long COVID? Because with long COVID, there's still so much more that I think we've got to learn about it. Obviously, people are sort of people are kind of understanding more and more about it every day. So how important is it to have this kind of data and this kind of clinical sort of standardization?
So, I mean, one of the problems with COVID has been working out what the syndrome is. And so where people are able to record standardized information in a nice granular fashion, if we can then get to that data, hopefully we'll begin to understand, how frequently do people get this particular sort of complication, or how often is joint pain a part of the syndrome, and things like that. Because at the moment, everybody's learning, and if we don't have a nice, easy to code process for the clinician, it's going to take a long time before we understand the full extent of all of the associated symptoms, etc. So having a coding process, a clinician-friendly coding process, undoubtedly helps in that.
Thanks very much, Paul. Another question, it says, how are we recording post-COVID symptoms in children under 18 years of age? I'm not sure if anyone wants to kind of jump in and answer that one.
I can start and maybe then, turn it over to Paul and or June. Once again, our terminology is created. One of the ways it's created is by feedback from end users. Our criteria for creating a clinical description is no more complicated than, is it clinically relevant and is it non-ambiguous? We are not limited by the floor of any particular terminology or code set. So if there is a need, as there absolutely will be, to say, COVID-19 manifested in a pediatric or even more specific adolescent, or as specific as in a 14-year-old presenting as X, we will create that term. We then turn it over to people like June to say, well, these are the appropriate SNOMED and ICD codes that come the closest. But the clinical description could be as finely detailed as the clinical world needs. And Paul, did you want to add to that, or?
No, I think that covers it well. Yeah.
There you go.
And then a final one had from Nick. It says, how does IMO interface terminology compare to NHS documentation standard requirements?
I'm gonna let you start this time.
So that's an interesting one, because it depends on what sort of a person you are when it comes to these standards. I would say that most clinicians in acute care are not sort of that aware of the extent to which one can define a condition by using SNOMED or ICD-10. And of course, the peculiar schizophrenia that we suffer from in this country is that the NHS has said you will describe conditions using SNOMED in the front end, but for the purposes of contracting and activity and revenue generation, that all has to be translated into ICD-10, and that's a bit weird. Why not just use the same? But that's where we are. What IMO does is it allows me to put in a sequence of words that feels natural for a clinician to be using, as opposed to a SNOMED expert. Because SNOMED experts will pick something that I might never have heard of as a clinician, because it actually does describe things much better. But with IMO, I can put in the more natural language entry, and it will map to the better description in SNOMED than I could have found, within a few seconds. So that's a real benefit. And generally speaking, as IMO gets more and more mature, and it is very mature now, but it can always change. It can always introduce new terms. I think it's a much nicer way of clinician-based coding than just raw SNOMED. So I think most people would find it a much more comfortable interface.
Thanks. And we have had conversations with people at the NHS that they have no issue with using a more clinical language, more comfortable, to quote Paul, to capture the clinical intent, as long as that structure follows along, behind it, so that at the end it is represented in the way that their standards require. So it really is the best of both worlds. We are, once again, to go back to that statement, we are not supplanting anything. We think we're providing a smoother path to people who are not SNOMED experts, to be able to get through their day and not just abstract to, you have COVID, or you have, lung cancer, or you have kidney disease, and move on, which is what we tend to see when we make people live in these code sets.
And
Sorry, June, do you want to?
no, please go ahead.
Yeah. I mean, one of my bugbears is that people quite disconnected from frontline medicine come up with code sets which are subsets of SNOMED that you have to use if you're to get paid or have your patient registered in national registry, etc. So an example is that most clinicians, most physicians would understand what I mean when I say this patient has diabetic nephropathy. It means that they have renal disease associated with diabetes, and that could be diabetes type 1 or diabetes type 2, but you'll derive that from the fact that further down the problem list is also diabetes type 1 since the age of 6, and now at the age of 35 they got diabetic nephropathy. That tells you a very clear story. I've got an example where currently the SNOMED term that the renal registry requires is this: renal disorder associated with type 1 diabetes mellitus. Nobody would think of putting that in as a search term. And so when they're looking for diabetic nephropathy, which is what they naturally feel they want to enter, they don't get it. And that's where IMO can help. In fact, in this case, we're having a discussion with the registry about changing some of the terms that they seem to have randomly selected as being the term that you have to select. But that's a good example of how getting the terminology right is really important for the clinician.
Yeah, and I was just going to add, from the perspective of looking at the codes on the back end, not actually documenting on the front end personally, but reading a lot of documentation over my career, the important piece is to accurately capture that patient's clinical condition that Dr. Altman just described. And then the code sets will follow. And then the accurate information for all types of uses, as we discussed, are available. So facilitating that is just key.
And then I guess data is always kind of linked to having so many benefits, I guess, and especially now as kind of we're coming through a pandemic. What are the benefits of having this, I guess, both on the patient side and the clinician side? Obviously, the clinician has the chance to put in more detailed data about the patient, or information about the patient, sorry. So what exactly are the benefits? Is it just kind of improved patient care, or do you think there's other things as well? Open to anyone.
Paul, you, me?
Well, undoubtedly, it will improve patient care for two reasons. One, in relation to the patient in whom you've entered that term, but then the wider population in terms of population health, when you're looking at population health analytics. For that patient, if you make it easy for people to enter the past, what we call the past medical history, which is the thumbnail sketch of someone's medical career, it's a massive benefit for anybody looking after the patient thereafter, because they can look at the past history expressed in the problem list and say, oh, I see that you had pneumonia, it resolved completely, but you were left with some chronic lung problems, you know, how is that? And it just makes the whole interaction with the patient much slicker. It gives the patient confidence that you know what's going on, and of course you know what's going on because it's there right in front of you, as opposed to having to leaf through letter after letter looking for all of the things that people have embedded in letters as free text rather than pulling in as coded entries.
I'd like to emphasize that point. There's study after study that shows one of the factors decreasing patient satisfaction is when patients feel they're being asked questions that they've answered already. Mm-hmm. It erodes the confidence that they have in the physician and the system. I told you last time I had shortness of breath due to COVID. Why are you asking me that again? So of course, patient care improvement is something we're all striving for. Of course, we think looking at the data and research and analytics, as I said, retrospectively, prospectively, and so on. But let's not forget the patient on the other end of that chart who doesn't want to keep telling the story over and over again about how they had COVID, they thought it resolved, but they had pneumonia, and then they still have some lung problems. Yeah. I told you that, a week ago when I was here, but we see a lot of patients in 7 days, and we may have to re-ask that, but we don't if the story is preserved in front of us. Yeah. So that should not be overlooked, is the patient satisfaction aspect of it.
The other thing, of course, is that in the primary care setting, especially in the UK, our GP colleagues have been used to use coding for many, many more years, and I would say that many more GPs are aware of the importance of coding. I mean, there are problems there as well, though, because they code everything, and they will code. Some of them will code a visit with a sore throat. And if a patient has been seen 25 times with minor complaints like that, you end up with either a diagnosis list or a problem list or whatever you call these things, where you begin to lose the wood for the trees. And I think that's where we aren't terribly good at standardizing that type of workflow across all clinical services in this country, at least. My problem list for my patient might have 12 items, but when I look into the GP record for that patient, they're 100. And in amongst that 100 will be my 12.
Did you want to add anything? Or no?
and that could be the problem with the problem list in the specialized world versus the GP. Could be a source for a whole series of webinars. Yeah. You just Google problem list and you'll get 25 articles about that on the first page. But this in our industry of clinical informatics, whether it's Paul dealing on the more clinical side or June and I dealing on the more data technical side, this is our charge, is to take this powerful thing that we've introduced, the electronic medical record, which has improved things dramatically. No one's going to argue that, but there has been a series of unintended consequences. Problem lists that nobody could read because I wrote them in my own hand. At least I knew how to read them. At least I knew how to retrieve the data, and maybe two other people who could read my handwriting. Now they become bloated, and with the automatic dump of coding information and bringing in CCDAs and other documents, there are clinicians who no longer look at the problem list. Dr. Larry Weed of the 60s would be rolling over if he realized that we were practicing medicine without using the problem list. And it really is an important tool. We need to allow the electronic medical record, the EHR, the EPR, whichever country that you're in. We need to return that back to being a tool that assists clinicians in practicing medicine, not as a hindrance, and something that we look at as an obstruction, but something that is, like a stethoscope or something else that provides us insight and clarity into caring for patients.
Yeah.
And I guess things like SNOMED codes and standardization has been around obviously for years, but do you think this pandemic has really shone a light on why we need this kind of clinical coding? Do you think it's kind of brought it to the forefront with things like long COVID?
Well, I'm going to turn it over to June in a second, but I would say absolutely. I mean, the idea that there are, as we've said, 2 or 3 ICD codes to describe everything. The fact that you have to capture different pieces of things to hope that you create a picture of something that someone else will divine that that's what you meant, in a month or so. But I think June probably has better insight into that than I.
Yes, I mean, it really has for all the various coding systems from, ICD-10 WHO down to individual country modifications and, what codes should be added and in what place that fit in with the guidance and structures of the current systems. As noted, ICD has activated some emergency U codes. However, when you look across the various countries, as Dr. Rube noted earlier, there's one code U071 adopted in the United States under the ICD-10 clinical modification. WHO has 2, and that was just to represent COVID and how the virus was detected. And then there's been, as we've seen, the disease manifestations, both acute and now long, evolve. How are those conditions classified? How do they work within the current systems has been a challenge, but a vitally needed ability to be able to document and to capture all those details, because as noted earlier, there are certain aspects of COVID-19 that we are still learning about and advancing our knowledge for.
It's interesting. I think COVID's obviously changed so much about healthcare and shone a light on a lot of things. So it'll be interesting to kind of see what happens in the next kind of 12 months. A question from Andy says, is IMO optimized for any particular cloud services provider? And can the data it collates be used for AI data analytics, via Google Cloud Platform?
Yes.
That's a simple answer.
The answer is we're optimized for all that. Yes, the service is often delivered via cloud. We have to be able to provide this in a way that is seamless to the end users. And because we are platform agnostic when we can be, it cannot be that everyone goes to an external place. It has to be both integrated and seamless and fast. And that is how we deliver it. If you think back, to answer the second part of the question, if you think back to the slide where I briefly showed the portfolio, I didn't want to spend a lot of time on that, but we do have products that are designed specifically for population health analytics, AI, powering those engines. Anyone who's involved in that type of research will understand that your algorithms, your engines, your brains are only that you're trying to create are only as good as the reference file, that you're looking against. And having one that is, if your charge is a clinical one, and then it only will improve to have one that's more clinically based, that's more granular, that's more specific. If you think back to that chromosomal abnormality slide, if you're doing research about chromosomal abnormalities of group C and X, it does not pay for you to have a cohort that contains everybody who has a chromosomal abnormality. So yes, for analytics, for AI, for all of that, this type of normalization that we do on big pools of messy data to normalize and provide structure, we have products for that as well. And if I can add to the previous question real quickly, you mentioned how COVID has changed so many things that that we're learning. If you think back, it was actually dramatic how quickly things changed a year ago. Every week there was a different treatment recommendation, and then it was, no, that doesn't work, and then we do this, and now we're seeing this is a complication. It was changing minute to minute. And if we weren't collecting good data, we would not have been able to move as quickly. So while we can improve and we continue to improve, the ability to look at the stuff and say, stop, the thing we recommended 5 days ago, it's not working. That would not have been possible for sure in the paper record or in the world of unstructured data early on. So whether you're capturing it as SNOMED or ICD or clinical interface terminology products like IMO offers, it was so important at the beginning that we had that. It really allowed for some of the the dramatic pivots that we were able to make early on. I think you're seeing fewer of those now, thank God. But at the beginning, we didn't know which way was up as physicians because it was changing. Treatments and conditions and descriptions were changing so rapidly.
I definitely think there's going to be a new sort of time in the history books of sort of BC and AC, before COVID and after COVID. I think will be a time in history. So another question. Oh, yeah, of course.
Sorry, I just wanted to, because that the changing and the ability to capture that as the code systems were dealing with that, IMO was also maintaining and updating. So the same intuitive language was still available, but yet the code maps behind the scenes were adjusting. So from that front end user perspective, that the ability to still capture the granular detail seemed seamless, while the ability with the code set data and structures was happening behind the scenes in that capture and that maintenance as well.
Thanks, Jean. Another question we've had come through says, is there a time signature for problems, which is kind of put in sort of air quotes, to enable filtering? So filtering to discount minor problems from chronic ones that could also allow deeper searches.
Yes, there absolutely is. We do that on several levels. Without getting into the technical details too much, we do have the ability. First of all, the EPRs have the ability to do that as well. But we do have data elements when we provide that. So we can look at things like, we can look at a problem list and say, someone's been pregnant for 3.5 years. That's probably something that should be cleaned up. An acute otitis that's lasted 9 months either should be resolved or, substituted for a chronic otitis. So we absolutely have time flags that we could look at that allow for filtering and cleanup efforts and I like the use of problems in quotations, because we do describe, as an interface terminology, it's not my job to tell you what is a presenting complaint, what's a chief complaint, what's a diagnosis, what's a symptom. I don't know. That's up to you to decide. We put them all in one suitcase and we say, we're going to call them anything that can affect the condition of the patient, we'll call a problem, even if it's, well exam. And you tell me how you want to use it. So the answer to that is, yeah, we do have time signatures for that.
Nicely done. And I think that's quite an interesting stat. You said NHS, sorry, I'm so used to saying NHSX, it just rolls off my tongue. You mentioned the NHS estimates that 1 in 7 people testing positive for COVID continue to have symptoms at 12 weeks. And are these kind of statistics, do you think, similar in other countries, or do you think it's kind of just in the UK?
Yeah, there was a recent article published by the Journal of American Medical Association with the statistics around 10% of patients who've been tested positive for COVID-19. So while they do not exactly align, they're very similar and close. And and I think that those statistics will continue to be published, but I would believe that they'll be very close in range together internationally.
Yeah, I would expect that to be the case. I think, across populations that are fairly similar in phenotype, it's going to be much the same.
It'd be interesting to kind of compare, obviously, kind of across the globe, which I'm sure the data will eventually come in, hopefully at some point, as kind of gathering so much over the last couple of years. So we've only got some. Oh, sorry. Did someone say that?
I was just going to add to that data comparability and analysis is based upon capturing it in that structuredized format and fashion. So we can see, if it's just within your own patient population, the country's population, and then compare it internationally as well. So.
Thanks, Jean. And we've got about 6 minutes left, and I'm not sure there's too many questions coming through. So I was just going to ask, particularly you, Stephen and June, kind of what do you hope, and Paul, if you fancy it, kind of what do you hope people will take away from today's kind of webinar? What do you hope they've learned, and what do you hope you sort of informed people of today? Stephen, do you want to start? Put you on the spot.
Sure. I hope what people take away is the understanding that there's a need to allow clinicians, and COVID just magnified this, to say what they want to say quickly and efficiently. Let's not try to make clinicians, once again, doctors, nurses, anybody taking care of, let's not try to make them coders. They're the worst data entry people out there, in my opinion. Let them do what they're trained to do. Let them do it well. The importance that they could capture the most accurate data at the point of care. We know the most accurate data is captured at the point of care. And then we need to use it downstream is predicated on the fact that we do that first step correctly and accurately. It's not my job to teach people how to use the administrative code sets. They should practice medicine, they should do it well, and then we should let the machines and the administrative sets take care of the business they need to down the line. And that's predicated on giving them a vocabulary that has structure that they can use.
I would just echo that. That is my goal, that folks take away that, painting a patient's details in order to have the information up front for all the reasons is really key, because capturing that patient's story and that patient's journey, it is just so important. And if you think about it, even from if you have to encounter medical services for yourself or your family members, you want that provider to have the information that is specific to yourself or your family member to make the best care decisions, and facilitating that process is vital.
We'll give the gentleman from Oxford the last word.
Yeah. his
So-
UK argument.
That's right. He has the accent or the lack of accent.
I'm not sure about that, but I mean, I think getting problems into the digital record is vital if we're to exploit the digital records to their fullest. It's, as we've already said, incredibly important for the individual patient, both from a safety perspective, an experience perspective, you name it. There's so many benefits. Population-wise, similarly, the one thing that I would like to see change, though, is at the moment, it feels like a sort of uphill struggle to get our younger doctors still in training, postgraduate training, to really appreciate why all of this is so important. And when I think about it, in reality, I'm not surprised that it's hard to do that, because there's very little about this in the medical school curriculum. And we really do need to start changing the curriculum to incorporate the concept of digital working and some of the do's and don'ts that we should all have sort of drilled into us in terms of the new way of working. In the UK, it's still very new for acute care compared to the situation in general practice or in other parts of the world.
Lovely. I think we're going to have to wrap it up there. We're sort of 2 minutes ahead of schedule. So that gives me a chance to say thank you to everyone who's tuned in to today's webinar. And thanks very much to our panel, to Stephen, Paul and June. Thank you very much. And thank you especially to Stephen, who has got up at 6 a.m. to join us today, which is a monumental effort and something maybe I couldn't do. So well done, Stephen. Just a quick plug from us. We've got a packed schedule of webinars, events coming up in the next few weeks. Our next one is on the 8th of June. Excuse me, it's a fantastic regional event. It's based on London. We've got Lisa Emery and Luke Redman, who are going to give 3 insightful sessions from peers in the London area, excuse me, showcasing the best practice and updates on the great work that's being done there. I'm about to have a coughing fit. Sorry, so I will leave it there. So please make sure you go to our events page and register for plenty more. So that concludes today's webinar, and thank you very much for everyone who's joining.
Thank you. Have a good day.
Thank you.
Thank you. Great.